Assalamu alaikum. I'm your moderator, Dr. Nida. Assalamu alaikum. Welcome. मेरी तरफ से a warm welcome to all the participants, the speakers and the panelists. We start the program. Sorry for the interruption. थोड़ा सा internet connectivity में issue था. अभी भी थोड़ा सा settle down हुआ है. Yes, it's okay. And I'm working as an assistant professor at National Institute of Diabetes and Endocrinology, and I've done my internal medicine at CPS, and I've trained in endocrinology from Bakai, and it's a pleasure, and I'm very obliged that I've been selected as a moderator, because the two institutes which are participating today, BIDE and NIGHT, one is my institution in which I'm working. So thank you very much. Let's start the program. As you know that Pakistan Endocrine Society was founded since 2003, and since 2003 it's been working for the collaboration and to spread the clinical endocrinology among all over Pakistan, and it is basically a scientific, educational and charitable organization, and it's devoted and motivating the students, the postgraduates and the fellows for research and clinical endocrinology, and even they have given grants for the international travel, conferences, research. So it's Pakistan Endocrine Society is playing a very big role in endocrinology, and this is a session of a clinical case discussion in which the period of COVID is very disturbing for all of us, less interactions and less conferences and less clinical meetings. So I think that in this period, it is a very good initiative from PES that they have started the clinical case discussion. So without further delay, program officially with the name of Almighty Allah and with the Tilawat-e Quran Pak, and then with the national anthem, and then we proceed to the program. So over to you, the guest people.
أعوذ بالله من الشيطان الرجيم.
بسم الله الرحمن الرحيم.
الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان خلق الإنسان من صلصال كالفخار وخلق الجان من مارج من نار فبأي آلاء ربكما تكذبان رب المشرقين ورب المغربين فبأي آلاء ربكما تكذبان مرج البحرين يلتقيان بينهما برزخ لا يبغيان فبأي آلاء ربكما تكذبان يخرج منهما اللؤلؤ والمرجان فبأي آلاء ربكما تكذبان وله الجوار المنشآت في البحر كالأعلام فبأي آلاء ربكما تكذبان كل من عليها فان كل من عليها فان ويبقى وجه ربك ذو الجلال والإكرام فبأي آلاء ربكما تكذبان
जी मैम आपकी आवाज आ रही है
आवाज आ रही है जी welcome again welcome to all my panelists my honorable panelists so we have 3 sessions of clinical cases here first will be presented by Bakai Institute of Diabetes and Endocrinology and for the panelist we have Dr. Zahid Miyan who is assistant professor at BITE and he's a consultant physician and endocrinologist and Dr. Musarrat Rayaz she's an associate professor at Bakai Institute of Diabetes and Endocrinology she's also having a degree in FCPS medicine and endocrinology and a lot of work at research. Please, I would like to invite Dr. Saima Askari. She's a speaker and she's a fellow at Bakai Institute of Diabetes and Endocrinology and she'll present the case. Please, Saima, start your case. Okay, I think Saima is not here yet. Sorry for the interruptions. I think we should proceed to the second case. I hope Nazish is here. Dr. Nazish? Dr. Nazish Fatima, can you please share your... Okay, well, fine, good enough. For the second case, we have the participants and the speaker is Dr. Nazish Fatima and she is a fellow of endocrinology at National Institute of Diabetes and Endocrinology, Dow University of Health Sciences. And for the panelist, we have Dr. Professor Akhter Ali. He is the head of department of NIT and he's a professor of medicine and he's having a keen interest in research work and the second fellow which is she's my colleague also Dr. Zareen Kiran she's an assistant professor at NIT and she's also a physician and endocrinologist she's FCPS medicine and FCPS endocrinology and supervisor at Dow University of Health Sciences. Kindly start your program, Nazish. I think yes you're getting
Assalamu alaikum. Is my screen visible?
Yeah, it is.
Okay, thank you. Assalamu alaikum. My name is Dr. Nazish Fatima. I am fellow in National Institute of Diabetes and Endocrinology, Dow University of Health Sciences. I am going to present the case of a patient. Am I audible?
Yeah, you are.
Okay. A case of hypophosphatemic rickets. She was a patient of 25-year-old female, single resident of Quetta with no known prior comorbidities. She presented to endocrine OPD on 22nd February 2021 with a complaints of bone pain and backache for 5 years, right leg pain and numbness for 5 years, and proximal muscle pain and weakness for 5 years. According to my patient, she was in a usual state of health Then she developed progressive bone pain and backache, moderate in intensity and associated with proximal muscle weakness. She also complaining of difficulty in climbing the stairs and also complaining of difficulty in standing from sitting position. She was also having numbness in right leg, and for these complaints, she went to general physician in 2016, and she was diagnosed with vitamin D deficiency and started on vitamin D replacement and calcium supplements. In history, there was history of recurrent toothache, dental caries, and teeth extraction. There was no history of any hearing loss, no history of any loose motion, epigastric pain, abdomen, constipation, anorexia, and weight loss. And there was a history in his her father. Her father has some bone disease which is undiagnosed. He is bedbound and his workup was not done. She has 3 brothers and 6 sisters. All are healthy except the elder sister who also has some bone problem but not investigated because of the financial issues. There was there was no reported history of any rickets, osteomalacia, or another metabolic bone disease in the family. She took vitamin D supplements and analgesics for the few years. Now she is not taking any regular medication. She is taking dairy products and meat regularly. Her menstrual history was unremarkable. She attained menarche at the age of 13, and there was no any association between her menarche and her symptoms. This is the pedigree of the patient. This is showing that we are suspecting that his father is having bone disease and he is bedbound since the age of 5 years. That we are suspecting that he is having some bone disease which may be extinct hypophosphatemic rickets, and this is affected father, and her mother is normal. And as she was saying that there is a history of her elder sister is having some history of bone disease, so it may be affected. And this is my patient. On examination, she is young female, conscious, oriented with time, place, and a person, sitting comfortably with a blood pressure of 130/67 at the time of presentation, pulse of 84 beats per minute, weight of 64, and height of 143 centimeters. BMI, which was calculated, was 31.3 kg per meter square. Thyroid examination was normal. There was no acanthosis, and star pigmentation. On physical examination, did not show any apparent kyphosis or scoliosis of the spine, vertebral tenderness, or hyperextensibility of the joint. She had a proximal muscle weakness with a power of 4/5 in both upper and lower limb. There was a tenderness in the thighs. Her neurological examination was otherwise normal. She had a waddling gait, and there was a prominent bowing of legs, more of the right leg. These were the investigation which we presented to us in the OPD for the first time. The PTH which was done and these investigations was done on 21st November 2016. Her PTH was 65, which is up to the upper limit of normal, and her vitamin D, that is 25 hydroxy vitamin D, was 22, which was replaced at that time. TSH, total T3 and total T4 was within normal range, and her alkaline phosphatase at that time was 186. Then few investigations was done before she presented to us in OPD, in which her repeated PTH was 89, which is now higher than the normal limit. The previous was 65. Now her vitamin D is 59, which is replaced at that time, but it's still 59. Alkaline phosphatase was 112, which is also above the normal, and her albumin was 4.9. Then we advised few investigations, which was done on 2nd March 2021. Her CBC was normal with normal HB and MCV, LFTs, FLPs, HB1C, and B12 levels all were within normal range. Her urea creatinine was normal, her calcium was 9.5, and her corrected calcium was 9.56. Serum phosphorus was 2.1, which is low. And her magnesium, so serum sodium, serum potassium, serum calcium, and serum bicarbonate was all within normal range. Her bicarbonate was 24. On the basis of low phosphorus, raised alkaline phosphatase, and PTH, we advise some urinary electrolytes. The urinary electrolytes which was done was showing urinary magnesium, sodium, potassium, and chloride, which was all within normal range. And her urinary calcium was low, that is 48, and the normal range is 100 to 324 hour sample. The urinary phosphorus was 552, even though she is having low phosphorus in her serum, but her serum urinary phosphorus is still within the range, that is 552. It should be low because she is having low serum phosphorus. It means that she is losing her phosphorus in the urine. Then we calculated some parameters. The fractional excretion of phosphorus, which was calculated, was 32, and her fractional excretion of phosphate of greater than 15% in the presence of hypophosphatemia confirms the presence of renal phosphate wasting. The tubular reabsorption of phosphorus, which was calculated in this patient, is 68%, and the TRP in X-linked hypophosphatemia is 60%, and normal TRP exceeds 90% at the same reduced serum plasma phosphate concentration. So she should have a increased TRP, but her TRP, that is tubular reabsorption of phosphorus, is still 68. Then we calculate another parameter, that is TMP-GFR. The TMP-GFR is the ratio of the maximum rate of tubular phosphate reabsorption to the glomerular filtration rate. The TMP-GFR may be useful in the assessment of renal tubular reabsorption of phosphorus in the following circumstances. It helps in the diagnosis of X-linked hypophosphatemic rickets, autosomal dominant hereditary hypophosphatemic rickets, autosomal recessive hereditary hypophosphatemic rickets with hypercalcemia, and oncogenic osteomalacia. Her calculated TMP-GFR is 1.48. And the range, which is in 25 to 35 years of age, is 2.4 to 3.6. And our patient is having 1.4, that is below the normal range. So we advised you X-rays, which was showing an incomplete fracture at the distal femur, and there is degenerative changes at the knee joint. This was the fracture. This is another X-ray which is showing an incomplete fracture with the bowing of the femur. This is the X-ray of the palus, which is showing another incomplete fracture at the proximal femur. This is the X-ray of lumbosacral spine, which is showing lumbar lordosis. This is lumbar lordosis with the osteophytes marginal. Then this is the X-rays of her humerus, right humerus showing bowing of the humerus with deformity. And this is the left X-ray, which is also showing shortening and bowing. Then the case summary is a young female with no known comorbids, complaining of bone pain, deformities, and proximal muscle weakness for 5 years. Reduced serum phosphorus, but normal urinary phosphorus excretion, normal calcium, and increased 25-hydroxy vitamin D3 after treatment with vitamin D supplements. Raised alkaline phosphatase and slightly raised parathyroid hormone levels. On the basis of history investigations, our diagnosis was hypophosphatemic rickets, and she was started on conventional therapy of soda first, that is 15 ml 8 hourly, and 1 alpha tablet 0.5 mcg OD, and followed by twice with repeat serum calcium and phosphorus. On follow-up that was done on 15 March 2021, showing a serum calcium of 9.6 and phosphorus of 2.2, which was still low, and then her soda first dosage increased to 10 ml TDS and continue with the 1 alpha new at 0.5 mcg OD. Now I will discuss a little bit about hypophosphatemic rickets. Hypophosphatemic rickets is a genetic disorder which prevents sufficient reabsorption of phosphate in the proximal renal tubules, with increased phosphate excretion resulting in rickets. And there are many different forms of hereditary hypophosphatemic rickets. Can you hear me? Can you hear me?
Yes, please.
Yes, we can hear you.
Okay. There are many different forms of hereditary hypophosphatemic rickets. I will just focus on the most common form, that is the X-linked hypophosphatemia. It's X-linked dominant, and 80% of the cases present with this X-linked form. There is mutation in the gene of PES, that is phosphate regulating protein with homology to endopeptidase on the X chromosome, which is expressed predominantly in the bone and teeth. There is an activating mutation resulting in increased phosphatonin, that is fibroblast growth factor 23 production. In this, the clinical manifestations are renal phosphate wasting with normal serum calcium, normal or low urine calcium, urinary alkaline phosphatase, normal or paradoxically high intake parathyroid hormone, rickets or osteomalacia, delayed dentation, dental abscess, craniofacial abnormalities, hearing loss, and hypertension, nephrocalcinosis. Almost all the complaints was present in my patient. Then the second form, which is autosomal dominant hypophosphatemic rickets, 20% common. There is the gene located on FGF23, and there is the anaphylactic leaf FGF23, leading to elevated serum levels of fibroblast growth factor 23, leading to the clinical manifestation which are similar to X-linked hypophosphatemic rickets, but the age of presentation and penetrance is variable. There are different other forms, that is autosomal recessive hypophosphatemic rickets, which are further divided into type 1, 2 and 3 on the basis of genes involved. And there is another form, just hereditary hypophosphatemic rickets with hypercalciuria. It is autosomal recessive and the gene involved is different. There is defect in the proximal tubule of sodium phosphorus co-transporters, leading to phosphate wasting in the urine through the proximal renal tubules. And there is hypercalciuria. The difference between this is that the patient also having hypercalciuria. And then another form is hypophosphatemia, hypercalcemia, and nephrocalcinosis, in which there is also involvement or abnormality in the sodium phosphorus co-transporter. This is the pathway of renal phosphate wasting in hereditary hypophosphatemic rickets, which is showing the gene involved. That is vaccine involvement in X-linked hypophosphatemic rickets, and there is DMP1 or ENPP1 gene in autosomal recessive hypophosphatemic rickets. Because of the genetic mutations, there is increased fibroblast growth factor 23 levels, which lead to separation of the sodium phosphorus co-transporters and leading to decreased phosphate reabsorption from the proximal renal tubules and leads to the manifestation of hypophosphatemic rickets. The treatment, that is the conventional treatment which we offered to the patient, was both activated vitamin D, calcitriol or alpha calcidol, and phosphate are usually required. Recommended dosage of calcitriol is 20 to 40 nanogram per kg per day, divided into 2 to 3 doses, with an elemental phosphorus dosage of 20 to 40 milligram per kg per day. We are giving our patient 20 mg per kg. This is the trial showing the randomized double-blind placebo-controlled phase 3 trial relating the efficacy of burosumab anti-FGF23. Actually, this is then a monoclonal antibody against the FGF23, which is the main culprit of the disease. And this was done and showing that there is improvement in the phosphate homeostasis, vitamin D metabolism, consistent with the pharmacological action of burosumab to attenuate the FGF23 activity in vivo. This is another article showing the evidence of benefits of burosumab therapy for X-linked hypophosphatemia and other conditions in adults and children. Burosumab is an FGF neutralizing 23 neutralizing antibody that has been a major subject of several recent clinical trials. There is improvement after therapy with increased renal tubular phosphate reabsorption, serum phosphorus, linear growth, and physical function. Also, reduced pain and severity of the rickets. The development of burosumab as a therapeutic agent has been transformative for the treatment of X-linked hypophosphatemia and is superior to conventional management of the condition, both adults and children. But as burosumab therapy is being adopted worldwide as first-line treatment for X-linked hypophosphatemia, displacing conventional phosphate and calcitriol therapy. Collaborative international patient registries are necessary to enable ongoing surveillance of its long-term side. Yes, I can.
Thank you very much, Nazish. It was a very interesting case. Now, I would like Professor Akhter Ali to please, sir, give your kind and expert opinion regarding and few comments regarding this case. Please, sir.
Hello, assalamu alaikum. Can you hear me, please?
Ji, sir. Ji, we can hear you.
I think it's a very good presentation by Dr. Nazish Fatima about hypophosphatemic rickets, which is very rare genetic disorder we see in our clinical practice. And usually we don't see that many cases in our clinical practice. And it's very rare this genetic disorder. As we all know, is X-linked dominant, sometimes can be transmitted X-linked recessive, and also autosomal dominant, and also autosomal recessive. And it depends because the females are less affected as compared to males, because male have only one X chromosomes. So that's the reason. If the mother is carrier, she passes the gene 50% to the son and 50% to the daughters, while father is the carrier, and then the gene is transmitted only to daughters, not the sons. It is a very common type of rickets in families, but it's a rare genetic disorder, and it is about 1 in 20,000 live births. The prognosis is very good if it's early, if we can diagnose early and treat the patient. As Nazish said about the treatment with the phosphate and the vitamin D, but now we have monoclonal antibodies, which is now worldwide standard treatment to treat the hypophosphatemic ricket. So I think it's a very good presentation, and it's a very rare disorder we see in clinical practice of medicine, not only in general medicine but also in endocrinology. Maybe some of the those patients can go to pediatric endocrinology. That could be the reason, but we don't see that many cases. And now, as I said, the standard of therapy is monoclonal antibodies to treat the hypophosphatemic ricket. And if we can make an early diagnosis, we can treat the patient, and there are a number of genes have been identified. I think the FX is most common gene, which is responsible for the rise in proteins, fibroblast growth factor 23, which is responsible for the excretion of the phosphate in the urine, and that leads to the hypophosphatemia, and ultimately it causes the softening of the bones. Thank you.
I would like to ask from Dr. Zareen that what are the complications of the treatment for this hypophosphatemic rickets? Can you please, Zareen, can you hear me?
Yes, I can hear. Assalamu alaikum, everyone. It's a very nice case of hypophosphatemic rickets, which was presented by Dr. Nazish. And I'm really thankful to Professor Akhter for briefly giving a nice overview of the whole pathophysiology and genetic cause behind this condition. So when you start treating this patient, you have to give the phosphate and activated vitamin D, that is calcitriol. There are two main complications which you have to, keep an eye upon. Number one is the development of nephrocalcinosis, and number two is hyperparathyroidism. So for both conditions, you have to, keep a good check on the calcium and phosphate level, not only the serum, but also the urinary calcium level, so that you can earlier predict whether the patient would be at risk of developing nephrocalcinosis and then renal stones, and then decline in renal function. And similarly, you have to keep an eye on the serum PTH levels, so that you can, preemptively decide about altering the management. So if you talk about preventing nephrocalcinosis, you have to monitor the serum as well as urinary calcium. And if that is on rising, that is, if hypercalciuria is developing, then you may add thiazide diuretic with or without amyloride, depending upon the electrolyte status of sodium and potassium levels. For hyperparathyroidism, again, you have to keep a check on the phosphate level. Sometimes you have to decrease the phosphate supplement, so that the stimulus that is high phosphate is not there for PTH to be released in excessive amount. And in this way, you can control the hyperparathyroidism. Obviously, the monitoring and management, long-term management, is quite difficult and cumbersome. But once these monoclonal antibodies take over the whole management, then it would be easier to manage such cases, because there is a lot of pill burden in such patients, and there are side effects like altered bowel habits and so on. So in that case, sometimes there is an issue of non-compliance as well. So yes, the management is quite challenging. Thank you very much.
Thank you, Zareen, for this brief giving brief monitoring and follow-up content. So the time is running out, so I would like to invite Dr. Saima Askari. She's a fellow of endocrinology at Bakai Institute of Diabetes and Endocrinology. And again, our panelists and respected panelists are Dr. Zahid Miyan, who is an assistant professor at Bakai Institute of Diabetes and Endocrinology, and Dr. Musarrat Riaz. She is associate professor over there. Please, Saima, can you share your slide? Yes, I can see your slide. Please start, Saima.
Thank you, Nida. Assalamu alaikum. Actually, we have logged in from our institute's system. That's why we did not receive initially sharing rights. Otherwise, we are with you from the start of the session. So, without further delay, I am Dr. Saima Askari. Dr. Zah has told that I belong to Bakai Institute of Diabetology and Endocrinology, Karachi. I am going to present two short cases. These are very important, common, although neglected from the society and the physician's perspective. I have started my screen sharing. I think you all are getting. So, these are two short cases I'm going to present. These are very common, important, though neglected from the endocrine perspective, from physician's perspective, and from society perspective as well. My first case is a 57 years old male who is a known case of type 2 diabetes for the last 21 years. He presented with a wound on left foot since 3 months. On examination, there was an extensive wound on the left foot. There was a history of improper footwear leading to infection. Patient was advised below knee amputation at multiple centers. Vitally, his BP was 140 over 90, pulse was 105 beats per minute regular, and febrile was 101 degree Fahrenheit temperature. On detailed limb examination, neurological examination showed monofilament and vibration sensors were absent in both lower limbs. PPT was 50 bilaterally, while his vascular examination showed all pulses were palpable bilaterally and his ABI was 1.06 bilaterally. On lab investigations, her HP is 7.1 gram per DL, his TLC was 17,000, platelets were 356, and his creatinine was 1.3 milligram per DL, whereas electrolytes and LFTs were within normal range. According to UT classification, he fall in 3B, that is the penetrate to bone or joint wound, and there is an element of infection is there. So he was fall in 3B. According to IDSA classification, it was severe because local infection as described above with the presence of systemic inflammatory response, as it is a temperature more than 38 degrees centigrade, whereas his respiratory heart rate is more than 90 beats and his WBC count was also 14,000. We planned as he was advised adhesion, debridement was done, IV antibiotics, and tissue CS was sent. These are some follow-up images. It was done 1 week later, then 3 weeks later, and gradually over 5 weeks, 7 weeks, and then 11 weeks later. And finally, after 13 weeks, patient almost healed. This is my second case. She's a 55-year-old female. She's also a known case of type 2 diabetes. For last 12 years, she is hypertensive for 5 years as well. She presented with swelling, pain, and discoloration of left heel since 2 weeks. On examination, her BP was 130/80, her pulse was 98 beats per minute, temperature 100 degrees Fahrenheit, and respiratory rate was 23 breaths per minute. Otherwise, rest of the system examination was unremarkable. Swelling and erythema of about 4 into 3 cm around right heel with purplish color change in center of wound. There was no discharge noted. There was a history of thorn prick present 1 month back. On detailed limb examination, neurological examination showed monofilament, pinprick, and vibration sensations were absent in both lower limb. VPT was 45 bilaterally, whereas vascular examination showed dorsalis pedis and posterior tibial artery and popliteal were feeble in left lower limb, while SFA was normal. In right lower limb, DPA, this dorsalis pedis artery and PTA was stable, while POP and SFA was normal. Her ABI showed from the left leg 0.7 or right 0.9. Her lab investigations showed HP 12, TLC 13,000, platelets were normal, creatinine was normal, electrolytes and LFT was also within normal range. According to UT diabetes wound classification system, she was classified as 0D. That is the wound superficial, not involving tendon, capsule, or bone, and whereas in D, infection and ischemia, both are present. According to IDSA classification, it's also fall in severe category. Her ultrasound Doppler was planned that showed focal lesion at SFA. So planned for revascularization. Then successful PUBA to the left SFA was done. We can appreciate here from this to this, we have restored the blood perfusion as well. So then we manage for incision and drainage, IV antibiotics, daily dressing, glycemic control and metabolic control along with statin, antiplatelet therapy, and direct thrombin inhibitors. And then proper offloading was also advised. These are some follow-up images. Gradually, she was getting better and finally wound was healed. The principles of ulcer treatment, these are very important. Some slides I have taken from the IWGDF International Working Group on Diabetic Foot Practical Guidelines on the prevention and management of diabetic foot ulcer. These show pressure of offloading, restoration of tissue perfusion, treatment of infection, metabolic control, and treatment of other comorphs and local ulcer care as well. Pressure offloading and ulcer protection. Why pressure offloading and ulcer protection are so much emphasized?
Because diabetic foot ulcer used to be located at pressure area, pressure increased local ischemia and inflammation. Moreover, pressure on the ulcer could complicate the ulcer. It exposes deep tissues, joints, and bone. And if there is absence of offloading, could cause impaired wound healing. And this has been proved that offloading has demonstrated more impact in diabetic foot ulcer outcome than other interventions like local wound care, like surgery, etc. These are some offloading devices. Total contact cast. This is upper is total contact cast. This is non-removable. This is also total contact, but this is removable. Or this is also offloadable device that is removable. And these are the ankle foot orthosis with accommodative footwear. This is a very good slide from IWGTF guidelines. It categorizes, stratifies the patient into 0, 1, 2, 3 according to their loss of protective sensation and absence and presence of peripheral artery disease. If it is 0, that is very low, there is no loss of protective sensation, there is no PAD, then screening frequency should be once in a year. Whereas if the patient falls in risk stratification 1, that is his risk is low. There is loss of protective sensation or PAD, because once every 6 to 12 months, he or she should go for follow-up. And if it falls in risk category 2, that is moderate, loss of protective sensation plus PAD, or either loss of protective sensation plus deformity, or either PAD plus deformity. So he or she is at high, moderate risk of getting ulcer. So once in every 3 to 6 months, screening frequency should be done. Whereas in risk category 3, that is the high, there is loss of protective sensation of PAD plus history of either ulceration, amputation, or end-stage renal disease. So these patients are at high risk of getting ulcers. So once in every 1-3 months, that means they are screened more frequently. This is structured foot care education, because we should follow these some important points of foot ulcers and their consequences. Preventive foot self-care behavior, such as they should not walk barefoot or in socks without shoes or in thin-soled slippers. Adequately protective footwear should be worn. They should go for foot checkup regularly. And practicing proper foot hygiene is also an important part of the structured foot care education. Seeking professional help in a timely manner after identified a foot problem is utmost important. These are some key messages. For proper management, it is essential to know whether you are dealing with a neuropathic or ischemic or a neuroischemic foot lesion, as the management a little bit different in between these two. Information on ulcer depth as well as on presence of ischemia and infection are basic features of any proper diabetic foot classification. UT classification can be used as a tool to guide you to assess the urgency of the management of the diabetic foot and prevent unnecessary delays. Similarly, diabetes control and comorbidities managing reduces risk for amputation and mortality, whereas the key point in local care is debridement and offloading. Peripheral neuropathy, peripheral arterial disease, foot deformity, history of previous foot ulcer or amputation are the most important risk factors for developing foot ulcer. Patients, this is also very important point, that patients are often unaware of the problem because of illiteracy, because of uneducation, because of neuropathy. They did not sense pain. Regular foot screening is required to detect foot pathology, to identify the patient at risk, and then manage accordingly. Targeted foot education is the key to prevent foot ulcers and amputation. Thank you.
Thank you very much. It was a very interesting case, definitely. Diabetic foot, can you hear me? Yeah, diabetic foot is a very important topic, and people usually, khas taur pe jo diabetic patients, they don't care about their foot, Saima. And I would like sabse pehle Dr. Musarrat Riaz to please give your expert comment and expert opinion regarding this case. Ma'am, please, can you?
Yes. Okay. Let me share. Okay. Thank you so much, Nida.
Actually, the idea of presenting these cases in endocrine meeting was that as our most of our fellows do have some exposure related to common endocrine problems, but diabetic foot is such which is usually remains neglected because there are very few centers who are doing a holistic approach. So I thought it would be a good forum to present. These are common cases. These are the cases that we see every day, and I know and I hope that everyone sees them in their regular practice. So the basic idea was to give the main outline that sometimes if you see anyone with amputation, you know how their life would be. So it's very easy to prevent these amputations, these unnecessary amputations, by following some simple measures. So that's why we have also invited Dr. Zahid Miyan. He's expert on diabetic foot. So I think he'll be in a better position to give the expert comments related to this foot. So I'll hand over this to Dr. Zahid.
We'll ask questions from Dr. Zahid.
Yes.
Sir, Assalamu alaikum.
Walaikum assalam.
Do you agree with me that after this endovascular procedures are being done and the angioplasties, so it's better for the patients जो के पहले bypass or graft or surgery के उससे गुजरते थे, अब we are more and more having endovascular procedures and their amputations are less because of the endovascular procedures nowadays.
Yes, in a sense. Thank you very much, first, indeed, for giving me this chance to interact with the people who might see these cases day in, day out in their routine practice. और जैसे कि डॉक्टर मुसर्रत ने कहा कि these are the cases जो कि most neglected होंगे और इसी की वजह से और जब suffering बढ़ जाती है and they increases the suffering of the people with the diabetes as well, and the cost of the diabetes and the burden on the society as well, the social as well as the psychological burden on people with diabetes. Regarding the two cases, yes, of course, as you asked me the particular question regarding the endovascular procedure. Yes, in Pakistan now we are lucky enough that we have few centers which are doing the endovascular procedure. I remember 10 years back that no one doing this one, and we were very handicapped with these when the patient comes with this problem with the need an endovascular bypass surgery, then the people really suffered with this one. Now, alhamdulillah, we have in our center and a few centers in the town are doing a remarkable job in their practices. And of course, when you are doing the endovascular procedure, like in this case, the second case, you can save the leg from the amputation. And very rightly said by the Dr. Musarrat that this is the unnecessary amputation which you need to save. There are sometimes we need to do an amputation when the life of the people with diabetes in jeopardy. Then of course we need to do an amputation as well. But it's very well presented by Dr. Saima in a very short time. One thing which I like to stress is this infection is mostly neglected by the family physician, by the general physician as well. So please do not neglect it and take time and do give them the right antibiotic, right doses for the right time period of the time. ये सबसे important है. This is the one of the most important. The infection is one of the commonest precursor of lower limb amputation in the low resource country like India, Tanzania, and there were papers showing that the infection is the cause of amputations. So we need to address the infection in a timely manner, because you know the time is the tissue. अगर आपने सही वक्त पे सही एंटीबायोटिक सही उसकी मकदार जिसको डोज कहते हैं डोजेज एंड सही ड्यूरेशन के लिए नहीं दी then the patient will lead to
Really an honor and for your valuable comments. And can we please थोड़ा सा टाइम शॉर्ट हो रहा है तो thank you sir Dr. Zahid, thank you Dr. Musarrat. Now I would like to invite Dr. Rana Tabassum, Professor of Endocrinology at Buckeye Institute of Diabetes and Endocrinology. And for the expert panel, I would like to invite Dr. Aisha Shaikh, consultant endocrinologist at AKU Khan University Hospital, and she is HCPS internal medicine and fellow of American College of Endocrinology, and she's also have trained in endocrinology from Khan University Hospital. And again, I would like to invite Dr. Musarrat. She is a consultant endocrinologist for the expert panel. And please, Rana, can you share the slide and start the presentation?
Assalamu alaikum everyone. Can you hear me?
Yes, Rana, go ahead.
Okay. My screen is visible as well?
Yes.
Okay, okay. Today I will be presenting a case of a young lady who came to us for the control of her gestational diabetes. So this lady, this was a 21-year-old primary gravida. She was referred from the antenatal clinic for the control of her gestational diabetes mellitus. At her first antenatal visit, the patient was diagnosed as she presented at 8 weeks at the antenatal clinic, and she complained of polyuria and polydipsia, and her blood sugars were fasting was 110 milligrams per deciliter, and a urine dipstick shows a glucose of 2 plus glycosuria. At that time, she was advised by her obstetrician dietary modification, and a follow-up visit at 2 weeks interval time was scheduled, but she did not return for the follow-up. At around 20th week, the patient again came to the antenatal clinic. At that time, she underwent 75 grams oral glucose tolerance test, and her fasting blood sugar was 115 milligrams per deciliter. Her 1 hour was 220 milligrams per deciliter, and 2 hour was 196. On the basis of these tests, she was diagnosed as a case of gestational diabetes at the time, and in addition to the dietary modification, her ObGyn prescribed her metformin 500 milligram BD. She was also advised to get an endocrine consultation for further management of her gestational diabetes. So this patient came to us at around 23rd weeks of gestation. At that time, she was taking metformin 500 milligram BD for last 3 weeks. She also complained of polyuria, polydipsia, and there was also complaint of polydipsia, which she attributed to with the intake of metformin. Her glucometer readings were still showing persistent hyperglycemia. There was no past history of impaired glucose tolerance or impaired fasting glucose, and there wasn't any complaint of any abnormal weight gain, hirsutism, menstrual irregularities in the past, and there was neither there was any history of polycystic ovarian syndrome. Her pre-pregnancy BMI was 25.2 grams per square meters. Her family history was unremarkable for diabetes. On examination, this was a young, anxious-looking lady with her vitals were normal and a lower normal BMI. There was no acanthosis nigricans on examination. Her thyroid examination was normal, and the rest of the systemic examination was also unremarkable. So she at that time she was advised HbA1c, which was 6.5. Her C-peptide level at that time was 2.3 nanograms per ml. Her thyroid function test were turned out to be normal, and her LFTs were also normal. As she was not tolerating metformin, and there was also persistent hyperglycemia,
She was advised, her metformin was stopped, and she was advised injection insulin of levomer at bedtime and injection aspart for her mealtime excursions. She was also instructed to follow self-monitoring of blood glucose, and the targets were for her were very much established, and she was counseled for the target therapy with a fasting value of less than 95 milligrams per deciliter, and our 2-hour postprandial should not be more than 120 milligrams per deciliter. She was given access to the 24-hour helpline service from the BITES 24-hour helpline service program, and for the adjustment of her SMBGs, and advised to follow up after a 7 days period. However, the patient this time again missed her follow-up, and again she was then lost to follow-up. A few months later, this patient came to our emergency department with complaints of fever and severe vomiting lasting for about 2 days, and an altered level of consciousness for the last 7 to 8 hours. She had a miscarriage at 7 months of pregnancy. She was not checking her blood sugar level postpartum, and she has completely stopped taking the insulin. So at that time, her investigations were showing that she has a hyperglycemia with a random blood sugar of 385 milligrams per deciliter. Her complete blood count shows leukocytosis with no evidence of focal or systemic infection. Her urine dipstick was positive for glucose and 3 plus ketones. Her electrolyte shows hyponatremia, and she was in metabolic acidosis. So at this time, this patient was diagnosed as a case of diabetic ketoacidosis, and she was managed accordingly. And she, following her management for the diabetic ketoacidosis, she was discharged, and she was advised for the again she was emphasized to get a regular follow-up, and she was on pre-mixing insulin with regular and NPH BD. Her further investigations were also done at this time, and her C-peptide levels showed were markedly low, and her anti-GAD antibodies were done, which were 3 times above the normal range. So the final diagnosis of this patient was made type 1 diabetes mellitus, presenting as gestational diabetes mellitus. Now, gestational diabetes mellitus, as defined by the as it is any degree of glucose intolerance with onset or first recognition during pregnancy. Now, there are certain points to consider what are the clinical features which are suggestive of type 1 diabetes in pregnant females, and what antibodies should be tested when we are suspecting autoimmune diabetes. Also, who are these patients who need to be considered for type 1 diabetes mellitus when they are presenting during the pregnancy. So there are certain clinical features which prompt us to suspect underlying diagnosis of type 1 diabetes. Number 1 is the younger age at the time of conception, a lower BMI, early insulin requirement during pregnancy, and presence of ketonuria and ketonemia. So I will be discussing a few cases from the literature. This is the first case. This was presented in the Journal of Internal Medicine. This is a 27-year-old lady who was diagnosed with gestational diabetes mellitus, and and this was turned out to be type 1 diabetes early in the postpartum period. This patient also had undergone 75 gram oral glucose tolerance measurement. Her GAR antibodies were also turned out to be positive. Another case report was published in the journal of this was done in Italy. They present 3 cases of adult onset diabetes in pregnancy. 2 of these patients were presented during early in the pregnancy, and 1 case was presented after in the postpartum period. Now, there are certain important things which we should be consider when we are dealing gestational diabetes mellitus. It was published in the IDF Atlas in the 9th edition. 1 in 6 births are affected by gestational diabetes, but the incidence and the prevalence rate varies depending upon the population. So it varies from 6 to 40% in various populations. Now, clinicians should keep in mind the possibility of new diagnosis of type 2 diabetes or type 1 diabetes whenever they are dealing with gestational diabetes. Although most of the time, gestational diabetes, later on patient develop type 2 diabetes, but we should keep in mind the possibility of type 1 diabetes, because there are certain clinical features which can be used to assess the risk of autoimmune diabetes. As I have mentioned earlier, these are younger age at conceptions, low BMI, early insulin requirement early in the pregnancy, and ketonemia and ketonuria. Now, pregnant patient at risk of type 1 diabetes should be identified to avoid further maternal and fetal complications.
See these kind of cases, and we should have to think regarding type 1 and type 2 diabetes in GDM. I would like to I would like to have a question from किसी ने सवाल किया है कि from Dr. Aisha Shaikh that can GDM women can fast although Ramzan to chale gaye. But can you hear me, ma'am?
Thank you, Dr. Rana, for a wonderful case presentation. So before I answer your query about fasting and GDM, I would like to say that regarding this case, most often you will be seeing all those run-of-the-mill GDMs, but there are situations like this where you will come across a woman who is having autoimmune diabetes and should be looking for such cases and be careful whenever such features are present, and start them on insulin therapy appropriately. This case actually has been an unfortunate because she had been non-compliant most of the time during her gestation period, and if she was coming to the medical care regularly, the outcome might have been different. She already has a pregnancy loss, and I hope some sense prevails with her and her family, and they take care of their diabetes adequately before she conceives in the next pregnancy. Regarding Ramadan and GDM, so if you look at the latest IDF DAR guidance, they suggest that even women who have GDM and are controlled on medical nutrition therapy alone might fast, but with caution. But all those women who are requiring drug therapy or especially on insulin therapy, they constitute the very high risk group. So because remember, these are the postprandial spikes in glycemia that are actually directly linked to fetal macrosomia. And during Ramadan, there is a period of fasting, then there's a period of high calorie intake in the during Sahar time and the iftar time, where a postprandial spike is expected, which can actually lead to adverse and fetal and neonatal outcomes. So that should be avoided.
Another question: what importance of postpartum follow-up regarding GDM, and हम कितने दिन बाद sugars और क्या कराएं, मतलब which HbA1c or fasting sugar for postpartum follow-up of GDM patients?
So during postpartum period, one will be the immediate postpartum period while the patient is still admitted and her blood glucose will be checked. Remember, whenever you come across a case of hyperglycemia in pregnancy, you can actually categorize her into a simple GDM case or one with overt diabetes mellitus in pregnancy, which means that she might be having pre-existing diabetes, and the others are all those women who had pre-existing diabetes. So for your run-of-the-mill GDM cases, mostly they will be having normal glucose values post-partum during hospital admissions. They will not require self monitoring of blood glucose later on. But since you want to classify their glucose intolerance status in the non-pregnant period as well, it is recommended that within 6 to 12 weeks postpartum, their OGTTs should be done. If there is some problem with tolerating that glucose load, then yes, fasting blood glucose and HbA1c can also be done. But OGTT, since it can show you two different glycemic abnormalities in terms of insulin deficiency and insulin resistance, both things can be observed while looking at the OGTT. That is a much better option. By the way, we'll be having a very extensive diabetes and pregnancy session in next week and the week after next week, the weekend, and you'll all get the flyer about that. So you'll get to know everything about hyperglycemia in pregnancy. This is a 3-lecture series, inshallah.
Have few closing remarks from Dr. Musarraf regarding GDM, and we'll end the session.
Okay, thank you so much. Yes, I can hear you. Thank you, Dr. Rana, for presenting this case. Actually, in the last 3 years, we have seen 2 or 3 cases who presented as GDM and then later they turn out to be type 1 diabetes. So the idea was to familiarize our participants, especially our endocrine fellows who will be dealing in future with these cases, that not all GDMs can be simple GDMs or type 2 diabetes. One should always be open to other options as well, especially the features that should be alerting, like in this patient, if you remember the slides, in her first antenatal visit, she had high blood glucose levels. So at that time, it should have been prompted immediately and immediate attention should be given. And this was a very unfortunate patient because she lost her baby. And after losing her baby, she just stopped checking her blood glucose levels and taking insulin, and so things multiplied. So the idea is to keep in mind that not all GDMs are type 2 diabetes. There are people who can present as subclinical insidious onset of type 1 during pregnancy, because pregnancy is a period of stress. So if a patient is needing insulin in the early days of pregnancy, either she's a diabetic patient before the start of pregnancy, or it might be a start of type 1 insidious subclinical onset. And there are so many reports in the literature that insidious onset of type 1 during pregnancy is there. So one should be very careful about this. Ideally, these patients should be managed in a combined team, ObGyn, diabetes or physician, endocrinologist. They should be on one page having close liaison with the patient. Unfortunately, that was not the case in this one, and we saw the consequences. And for future, we did counsel this patient. Let's hope she comply with the follow-up and she do whatever it's been advised to her. It's not very easy, because if you're not regular with the follow-up and if you do not impart the importance of monitoring blood glucose levels to the patient, to their families, these things will come up and will be happening again and again. And Dr. Aisha has very rightly mentioned that extensive CMEs has been planned, and I hope all of you will attend. So all your queries and questions regarding all the aspects of hyperglycemia in pregnancy, whether type 1, type 2 or GDM, will hopefully be covered in detail in those. Thank you so much.
Thank you, ma'am. Thank you very much. I think this was a very good session, and with the collaboration of guests especially. I am thankful to all the panelists who have given their precious time to us and share their knowledge among healthy discussion. And thanking everyone, especially Gets Pharma, for this collaboration and cooperation. And Tariq Majid Gori Saab, who has collaborated very well from Gets Pharma, and Dr. Ali Asgar. And thank you very much. We'll see you soon, inshallah. Allah Hafiz.